Para peserta simposium, acara selanjutnya adalah simposium dengan topik Transkateter Closure of VSD with Konar-MF Device, including low-weight patient, yang akan disampaikan oleh Dr. César Abelleira, serta dengan moderator yang terhormat Profesor Dr. Mulyadi MJer, spesialis anak konsultan. Untuk mempersingkat waktu, kepada yang terhormat Profesor Dr. Mulyadi MJer, spesialis anak konsultan, untuk memulai sesi simposium. Kami persilahkan.
Okay, thank you, Mr. Master Ceremony. Good afternoon, Dr. César. How are you? In Madrid, still morning, yes?
Fine, thank you.
Still morning, yeah. In Jakarta, afternoon. Yeah.
Afternoon, morning in Spain.
Yes. Thank you for joining in our session. Yeah. And before you give your presentation, I will read your short CV. Please show your CV. Yeah. Dr. César Abelleira Pardeiro, yeah. He's from La Paz University Hospital, Madrid, yeah, Spain. Yeah. He's recent graduate in medicine and surgery, yeah. Specialist physician and pediatrics, yeah. And subspecialization in pediatric, cardiology, and contractile disease. Yeah. We can see his CV in our country, and we read in Indonesia. Yeah. No, he worked in La Paz University Hospital, Madrid, Spain. Yeah. And please, Dr. César, to give your topic about transcatheter closure of VSD with Konar multifunctional device, including for load weight pain. Yeah? And your time around 20 minutes. Please, Dr. César.
Okay, I hope you will see my screen.
Yes, I can see here clearly.
Okay, first of all, I would like to thank you for the kind presentation, and also to the organizing committee for giving me the opportunity to share with all the colleagues in Indonesia our humble experience, knowing that you have a very huge number of this pathology in Asia, not so big in Europe. And sorry, we have changed only a little bit the topic of the talk, but I will talk also about the Konar experience. But I would like to center my talk in the transarterial closure or the VSDs, even in low weight infants, and the preliminary experience, the humble experience in our center. Okay. Only to begin, we all know that today the most important tool or technique for the treatment of the VSDs still is the surgery, not the catheterization, and there are several reasons that explain that. We know that most of the VSDs that present in the early life have a very big size, in continuity with aortic or other valves, and most of them are related also with other complex congenital malformation that need surgery to treat the patients. A lot of VSDs from the muscular septum, on the other hand, tend to close spontaneously, so they don't need to be treated. And there are a lot of concerns in the past about AV block in transcatheter treatment. Here in Europe, there were so many papers in the past years, so it made the procedure to stop in many centers or to lose them. Okay, which are in our current practice the best candidates for percutaneous closure? In our hospital, we used to treat small to moderate perimembranous VSDs, almost those associated with aneurysm of the septum, post-surgical residual VSDs also, Some muscular VSDs, mainly isolated defects, but this is not very frequent in our environment. And we don't treat in the policy of our unit, we don't treat membranous VSDs with aortic valve prolapse that we know in other centers do. In a quick review of our previous experience in the first decade of this century, the most important device approved for the closure of perimembranous VSDs was the Platzer perimembranous VSD device, which it had an asymmetric design. It was a little bit rigid and not flexible, the structure. Technically, it was a bit demanding. It needed an arteriovenous loop for antegrade implantation, and it needed to have the very proper position to be effective. And the most important thing is that, as I told you before, the concern about AV block, that it was published in many papers to be between 2 or 6%. So it wasn't enough to stop the procedure in many centers. In the years later, we tried to use this device. You know that is the Nitoclut device from PFM. As you know, it's an asymmetric device, similar to a coil, but it's not a coil, it's more rigid than a coil. It needs also it's needed also to treat, to do an arteriovenous loop in order to reach the VSD from the venous side. And we have any experience, more or less 10 patients with it. We felt the implantation was not easy, was not really predictable in all the patients. And the most important problem we had with this was the residual shunt that resulted in some patients in hemolysis. We saw in these cases low rate, but it was very few cases, a low rate of AV block, and it was published also in many papers. After this, we tried to use the many devices of label, as you know, the ADO or the ADO2. We use the ADO in many patients. You know, this is an asymmetric device that needs also to do an AD loop in order to put it from the venous side. Also, it's an asymmetric device. And we have used in this device to treat many VSDs from the perimembranous position, mainly those with aneurysm. This was an example of a case with arteriovenous loop, advancing the device from the venous side, opening the left disc, positioning the device, and after and the other example, we have done also some post-surgical defects. This was a patient that had been treated for Fallot disease. We have, after that, he had been treated with a pulmonary bioprosthesis surgically, and after that, we put a melody valve. He also had a VSD with a shunt between left ventricle to right atrium, and we closed also with the ADO device, as you can see, making an arteriovenous loop. We also tried to use these devices, you know them, as symmetric devices, which are ADO2 and Piccolo device. They have the asymmetric design. They are more flexible with low profile. So they can be put either antegrade or retrograde, and you can treat or even infants and low weight patients. We have done some cases in the first experience making an arteriovenous loop. This is an example of a patient that had been treated at the Pediatric of Fallot. He had some important residual lesions, and he was supported with ECMO. We did a catheterization. You can see an important residual VSD, also an important stenosis of the pulmonary arteries. And under ECMO support, we treated the pulmonary arteries, the right ventricular outflow. And after that, we treated the VSD. In this case, we had to make an arteriovenous loop between the femoral vein and the subclavian, the right axillary vein, in order to advance the device over the VSD, and to put, in this case, a piccolo device, a 550 piccolo device, to treat the VSD. And in most recent years, we have the Konar-MF from China device. This device, as you know, has the CE mark from May of 2018. As you know, you have talked about this before. It's an asymmetric device, an ethanol device. In this case, it's asymmetric with the right side a disc and the left side disc forming a unit with a waist. And the other thing is this device can be put or can be attached from the right or from the left side. So it can be implanted either from the arterial or the venous approach. So that's our series. You can see our numbers is not the numbers you have in ASEAN. From September of 2019, we have treated 20 patients with perimembranous, either post-surgical or native VSD. And from all of the 20 patients, we have done 12 patients with the retrograde access with different devices I want to show you. All of them were done retrogradely from arterial femoral artery. The median weight of the patients were 22 kilos. From the less weight was 2.7 kilos. And the age range from the median for age from 2 months to 38 years. The defect in this group was native in 7 patients, post-surgical in 5. The median diameter of the VSD was 4.5 millimeters. And the cubic QS in all was more than 1.4. Devices used were Konar in 4 patients, Piccolo in 3 patients, ADO 2 in 4 patients, and also ADO, the first device of the occluders in 2 patients, even it is not a symmetric device. Median device diameter was 5.5, as you can see, more or less 1 millimeter more than the defect. And all the patients were done by transesophageal echo, but we used transthoracic echo in 3 small patients also to control. These are the most important data of the series. You can see the age in years and months. The smallest one, you can see 2.5 months. The biggest one, 38 years. These are the weights of the patient. Most of the patients were premembranous VSD, also, although native, it's a native lesion, or either associated to other lesions as coarctation, Shawn disease, etc. And 2 patients were post-operative lesions, residual lesions, with the trabecular of a lot and double outlet of the right ventricle. These are the diameter of the defect, the cubic US. Most of the patients were done with 4 to 5 French, and these are the devices used in our series. I want to show you some cases. This is the smallest patient. This was a 6-month infant with a weight of 2.7 kilos. He had a previous history of prematurity and syndromic, and had, as you can see, an important native VSD with a cubic QS of 3. With cardiac failure, you can see here a left ventricular angiogram from the venous side through the foramen ovale, and the huge pass of contrast to the right and pulmonary artery. And we treated this case in retrograde access, as you can see, reaching the right ventricle. In the first attempt, we put an AVO2, and this case was the only had an embolization. You can see the device embolized to the left pulmonary artery. It could be recaptured and treated after that with another oversized device. Exit. In this case, the patient had a mild to moderate ventricular regurgitation, but in the outcome follow-up, the regurgitation was mild. This is another case, in this case 2.5 months, 4.5 kilograms. This was a post-surgical pains that had been treated of a VSD and coarctation. It had residual lesions, coarctation and residual VSD, and you can see in this angiogram, the flow was mainly from the left ventricle to the right atrium, and it was treated also with, in this case, a piccolo 5.2, retrogradely with 4 French without any complication and with total closure. This is another patient, in this case, 8-month infant, 5.7 kilos, with a Sean complex, a very complex malformation that had been treated, as you can see, with a she needed a mitral prosthesis. It had been treated also for VSD, coarctation, aortic stenosis, and had many residual lesions. One of them is VSD, you can see, and it was also treated with a piccolo device or retrogradely without any problems with this the device. This is a nice case of, in this case, an adult patient. It was a 26-year-old. This was a native VSD with, as you can see, an aneurysm tissue with 2 main holes in this tissue and flow between the left and right ventricle. His previous history of endocarditis, so we decided to treat this defect. And in this case, we did it with 2 devices. We cross both defects, as you can see, and we put in one of them an IDO device. In the other one, that was a bigger one, we decided to treat with an ADO, first generation device, retrogradely also, and you can see both devices in the echo and third generation of the devices without compromise and result. This is we had also our most recent experience is with the Konar device. We have had a very nice experience most recently with this device. We have done retrogradely 4 of the cases I mentioned before. This is a case of a 3-year-old kid, 15 kilograms, as you can see, is a native VSD, with also an aneurysm formation, and more than 1 hole in its defect. And we could also treat this defect for retrograde with a 5 French catheter. In this case, we open the right, we mounted the device attaching it from the left side. It simplifies a lot the procedure. We also have to cross to put a guide wire in the right ventricle to advance the catheter to the apex of the right ventricle. Care in the opening of the right ventricular disc, as you can see, the attached system, not to damage the muscular of the right ventricle. After that, we pull back and we are putting the device from the left side. In this case, the position was not good for us. We tried to reposition. And the other thing is that I think the tricuspid is more prone to be damaged because we come from with the right ventricular disc from the apex. far from the right tricuspid, and we protect the advancing left disc and waist from the aortic valve with the catheter, only pushing the left disc and waist. So you can see the final result, the total closure. All the 4 patients we treated with Konar device had a total closure without any event. So the results in the whole group was successful procedure in all patients with immediate total occlusion in 10, 1 embolized device, as you could see before, and same patient that was the smallest one and mild to moderate tricuspid regurgitation. We had no complication from the arterial access, and the mean fluoroscopy time was 16.3 minutes, which is less than the time we used to have when we do it from the inner side in arterial loop and in other patients. Follow-up is not so much. It's a recent series of patients, it's 20 months. We have had 3 exitus, but they were not related with the procedure, but they were all some difficult patients. One of them was the shown patient with pulmonary hypertension that include cardiac transplantation. The other one with things related with the syndrome was the small one patient, but had no any problem with the device and with the VSD. Another one with postoperative complications not related with the closure, the VSD closure, which was in situation without any problem. We have had no AV block in this short follow-up, and no other complication, and total occlusion in all the patients in the follow-up. So in my conclusion, arterial retrograde access for the closure of the membranous VSD, I think makes the procedure easier and feasible in infants and low-weight patients due to the low profile of many devices. Either symmetric devices as ADO2 and PICO or new asymmetric devices as Konar device are suitable for this approach. We have had no cases of AV block in our experience, but it's very short follow-up. We will see. Maybe due to this softer and more flexible design, it could be in these patients or in these cases more prone for the AV block, but it's only a theory right now. And specifically designed for this type of defects, Konar-MF device seems for us to be a very promising device due to its low profile and versatility. It's no more. Thank you very much for your attention.
Thank you very much, Dr. César, for your nice experience to share your pen to us.